Hello, everyone. I'm Arya, your host for today's session, and welcome to the FB Live, where we will be learning about intensive critical care. If you are Indian origin living in US and worried about your medical needs, well, eGlobalDoctors has your back. They have introduced package deals for you and your family members. So now get yourself consulted at a lower cost, where you can choose from our 300 plus board certified doctors from USA, UK, India, and other parts of the world. Prescription will be provided. Response time is 1 to 3 days. Video consultation is up to 30 minutes, and the packages can be used by yourself or your family members. For more information, visit eGlobalDoctors.com and register yourself now. In today's FP Live session, we will be exploring and providing more information about what is ICU, the different types of it, and what post-ICU care should be taken. We have with us Dr. Anup Katyal. He is the ICU critical care expert, board certified in internal medicine, sleep medicine, critical care medicine, neurocritical care medicine, and has more than 25 years of experience. Nice to meet you again virtually, and thank you for sparing your time with us for today. Welcome to the live.
Thanks a lot for having me.
So without a further ado, I am going to dive right into our topic, starting with our basic question. What is the intensive critical care or the ICU?
So ICU is a place where the sickest of sick come into the hospital. And when we talk of ICU, there are different kinds of ICU. So you have what we call as medical surgical ICU. You have what we call as neurotrauma ICU, and then we have CVICU. So there are different ICUs depending upon, the hospital and the kind of population you cater to.
Right. So when you mention different kinds, like I have heard about the PICU or the NICU, like are those it, or are there any different kinds to it? More to it.
So yes, so NICU may stand for neuro ICU, P may stands for pediatric ICU. So those are different kinds of ICUs. So depending upon, again, the age of the patient, what the underlying problem is, they may go to different ICUs. If it's a cardiac problem, we'll go to CVICU. If it's a trauma patient, we'll go to trauma ICU. If you've had a stroke, you'll go to neuro ICU. If you're post-surgery or you have a surgical problem, surgical ICU. And if you have a medical issue that leads to intensive care, then you'll go to the medical ICU.
Okay. So then if I may go into some particular details, like what kind of illnesses require this critical care?
So I will put it in a very basic format. We all know, when we talk of any individual, we say, what are your vital signs? So your heart rate. So if your heart rate is too fast or too slow, that may cause problems with your blood pressure. That will take you into the ICU. Respiratory rate. If you're breathing too fast, too slow, obviously there's a cause for it. That will take you to the ICU. We talk about temperature. If you're running a very high fever, or if your temperature is very low, and accompanied with that, if you have blood pressure issues, that will take you to the ICU. So if you check your vitals, again, as I said, if it's your heart rate, respiratory rate, blood pressure, if your blood pressure is too high or too low, again, there's a reason behind that, and that will take you to the ICU. So those are some of the, if you look at it from a basic standpoint, when you have a lot of hemodynamic instability, and whatever be the cause, whether it's a trauma, whether it is a medical problem, whether it's a surgical problem, whether it's a pregnant patient, any of those situations will then lead you go to the ICU.
Okay, thank you for that. So then what is the difference between this critical care and then the emergency medicine? Are these same, or there is a difference between this?
So if one is not feeling well and one feels sick enough, whether when one calls an ambulance or when one is transported by a near or dear one to the hospital, the emergency department is the first stop, where you're evaluated by an ER physician. And they do the kind of stuff what we would call as a triage, that if the patient, they first stabilize the patient. And depending upon how sick an individual is, if they think that the person does not need hospital admission, they send the patient home from the emergency department. If they think the patient is sick enough to get admitted, but not that sick to come to the ICU, they may admit the patient to the general ward in the hospital. But if they deem that this patient is unstable, and by that I mean someone needs to be put on the ventilator, or someone has a bad injury to the brain, or someone is in shock, whatever be the underlying reason, then that would certainly, make them stabilize the patient in the ER and then transfer the patient to the ICU. So ER will be a conduit for a patient coming into the ICU where they come from home or transported by ambulance. First stop in the ER, a quick look by the ER physician, make sure the patient is stable. And when I say stable, if the patient needs a breathing tube, they will put a breathing tube. If the patient needs certain medications, they will start those. And once the patient is somewhat stabilized, then the patient is transferred to the ICU for subsequent care.
Okay, so basically the emergency medicine would be the decision maker, whether to go ahead with the critical care.
Exactly. And obviously, when the patient comes in, they give a call to the critical care physician. We discuss the case and decide, whether this patient needs to come to the ICU or not.
Okay, perfect. So as you are the critical care and ICU specialist, I want to ask you, how do rounds work in ICU, and why do doctors do shift work?
So that's a very good question about why do intensive care doctors do shift work. I'll go with that. As you can imagine, ICU dealing with patients who are critically ill. Again, as I said, depending on the ICU you're working in, there is a lot of stress in managing not only the patient, but also the family situation, right? The near and dear ones, they're calling constantly, or depending upon the situation, we just went through the COVID pandemic, where visitors were not allowed at all. So they were totally banking on the doctors to give the call to the family members, updating them on a daily basis. So that was an added layer of stress to the doctors. So it is not possible for a critical care physician to work 7 days in a row. We usually work like 10 to 12-hour shifts. So that is why it's always shift work. We work several shifts a week, then need a break, and then come back. As far as the rounds are concerned, it's sort of not just the ICU physician that's involved in the management. Yes, he's the leader of the team, but he's well served by a number of other ancillary, if I may say, staff. And so the nurse is involved in the round. We have a pharmacist who participates in a round. We have a dietitian who participates in the round. Depending upon what's going on, we have a speech therapist who guides us, whether someone can safely swallow or not. Then you have, occupational therapy, you have physical therapy, you have social worker. So when we do round, we are surrounded by, because when we prescribe medications, the pharmacist is looking at, is it the right dose? Are there any drug interactions? Similarly, a dietitian is looking at the nutritional aspect, are we giving the right kind of diet to the patient? If they're being fed through an NG tube or an OG tube for nutrition, are they getting the appropriate nutrition, depending upon what the situation is? For example, if someone has kidney failure, then you don't want high potassium, high phosphorus diet. So all those are taken into account. So it's sort of a multidisciplinary team that takes care of the near and dear ones in the ICU.
Wow, that is just amazing. Great to know that. So what type of the specific medical conditions are treated in the ICU?
So I will go down, like if I'm working in the neuro ICU, then recently we had a very nice talk about management of acute stroke. So that patient we will see in the ICU. If someone comes with a head bleed, whether it is intracranial hemorrhage, or people may have heard the term subarachnoid hemorrhage, they will be in the ICU. If you have someone with bad motor vehicle accident and traumatic brain injury, they will come into the ICU. If you have someone, we suspect an infection in the brain that we call as meningitis or encephalitis. If you have neuromuscular weakness, which can be life-threatening. If you have spinal cord injury. So this would only be in the neuro ICU and trauma ICU. Then other situations would be, if you have a bad pneumonia and you need to be on a breathing machine. If you have a very common term used, sepsis and septic shock, that is basically an infection involving the bloodstream, which can involve multiple systems, that would bring you to the ICU, which we often see. If you have acute liver failure, if you have acute kidney failure, again, as I said, sepsis is a big thing, and respiratory failure. So any kind of, end organ damage or severe damage that we think is reversible, and sometimes not reversible, these patients will come to the ICU. In the cardiac ICU, we see patients with acute MI, with, arrhythmias, with, acute coronary syndrome. We in the vascular ICU that we see people with ruptured aneurysms. That's, thinning of their main blood vessel that goes into the belly. If it ruptures and they have surgery, they come. We see patients post cardiac bypass surgery. We see patients post valve replacement. We see people post, what we call as TAVR, that is not through open heart surgery, but through the groin, they go in and replace the aortic valve. So all these patients come to us post-op. So depending upon which ICU you're working in, you'll see a host of patients with, different conditions.
So then I have heard about this term. If you could explain, like, what is the palliative care?
So that's something, it's another field of medicine, actually. There's a specialization for that. And actually the word palliative comes from a Latin word, which means to wrap in comfort. So when we see patients, who are very sick and, living in the ICU, we can keep adding on and on and on, to what we can do to the patient. Yes, you have your heart not working, you have your lungs not working, now you see the kidneys failing, but you're looking at the reversibility of the condition, and that, things are not going to end well. So you need to have a conversation. Obviously, the patient cannot participate, so the near and dear ones, need to be contacted. So we always consult palliative care. They carry out a conversation with the family members, and then we also meet when we arrange for a family meeting. And palliative care means, providing comfort to the patient. It does not mean, withdrawing care, but making sure in certain situations when you have serious illness, how to control the pain, how to control anxiety, how to control, say, simple thing like constipation. So when we involve palliative care, they help us carry out this conversation with the family members. And one form of palliative care is hospice, where we think, a patient is not going to survive long and it's only 6 months to live. Then we will involve them to, transition care to keeping an individual just comfortable. So all I want the people to hear, palliative care does not mean withdrawal of care. It is just helping them, make their lives, the patients as well as the near and dear ones, comfortable. That's what the whole purpose is.
Right. Okay. So moving on to the next question, what precautions should someone take when visiting his or her loved one in the ICU?
So depending upon each institution you have visiting ours, the most important thing I would suggest is, hand washing before entering the room and once you exit the room. So there are always, alcohol-based, solutions that are available outside the room. So you should use that before entering, and then once you exit, make sure you wash your hands. And sometimes when people have certain infections we call as like C. diff, then alcohol-based solutions may not be the best. You must wash your hands with soap and water. That's the general standard everyone should follow. But depending upon the situation, I mentioned the C. diff. If someone has C. diff, then you cannot enter the room without wearing, gloves and gowning yourselves before entering. If you have certain conditions, you may have heard the term, or people may have heard, like MRSA. That's methicillin-resistant Staph aureus. That's a resistant bacterial infection, or VRE, vancomycin-resistant enterococcus. There are certain situations where then you would be asked what we call as contact precautions. If you enter, you have to wear gloves and gowns before you enter, and before you exit, you have to take off the gloves and gowns before you leave the room, because you don't want to spread the infection to someone else. One other thing that you will come across in this respiratory illness when we talk about is, wearing masks. And depending upon what one is dealing with, for example, if it's like an influenza or RSV infection, then you have to wear like a standard, surgical mask will suffice. But if you have particles which are less than 5 microns, which happens with tuberculosis or COVID-19 or SARS-CoV-2, then you have to make sure the patient is in a negative pressure room, and then you're wearing the N95 mask. So depending upon the situation, there are certain precautions. And we also tell everyone that, when you're visiting your near and dear ones, hospital is not a benign place. You've always heard this term of hospital-acquired infection. So we don't want, that environment to be sort of made worse. So we say, don't bring fresh fruits or flowers to your near and dear ones. That could be a source of infection. So those are common things that we tell, the near and dear ones before they're visiting the ICU.
Right. So putting on a gown or having a mask with you and washing hands.
Yes.
Right. So then moving on to the next question, what care should be taken if someone is suffering from psychological impairments and he or she needs to be under the intensive care?
So, we are facing a pandemic, at least in this country, of, narcotic overdose. And so other situations like, with the pandemic has added to the stress, psychiatric illnesses. So it's not infrequent that we see in the ICU, I should have mentioned, patients who want to commit suicide, take their lives, have psychological issues. They come through the ER. They always then get admitted to the ICU because, they have to be watched very closely, one-on-one. We then consult, the appropriate services, the psychiatric department and behavioral health, and then they make a determination when we clear the patient medically, whether they need to go into inpatient, rehab, or they can follow up as an outpatient, with their own psychiatrist. So we are seeing a lot of mental health issues, psychological issues surrounding this pandemic, and we are seeing an increase of similar patients, whether it's a drug overdose or whether it is, when I say drug, it's the opioid epidemic that we talk about here, at least in United States, and there are other street drugs. And then those patients generally have some underlying psychological issues that, makes them do these things. So for us in the ICU is again the same situation. A lot of times they're not breathing despite our best efforts. So we have to put a breathing tube and let the medicine, sort of dissipate from the system before we can successfully take the breathing tube out. So that's something that we see a lot these days.
Okay. And then how about if a pregnant woman needs to be admitted to the ICU, is there any different kinds of precautions to be taken there?
So if it's a pregnant woman, and we saw a fair number of pregnant women during this COVID-19 pandemic, unfortunately, 99%, I would say, of the pregnant women were not vaccinated and they had severe COVID-19 infection. So when you're dealing with a pregnant patient, obviously you're in most situations dealing with two individuals, the mother as well as the baby. So there are certain things, what's the blood pressure goal in that situation? What's the oxygen goal? In general, we have a higher target for pregnant women because we don't want the baby deprived of oxygen. And then there are certainly specific conditions, pertaining to pregnancy. People may have heard the term preeclampsia, eclampsia, postpartum hemorrhage, and these are conditions where as the pregnancy goes along, you have very high blood pressure with spilling of certain things called protein in the urine, or you have a seizure, during the third trimester. Then those are managed. And then after delivery, a lot of times we see people with postpartum hemorrhage. That was in the news in the Indian media recently. So those are some of the things we see in a pregnant patient around delivery. Plus, we have to be very careful about the medicines we use. So we always have the OBGYN people, is it safe to use this in pregnancy? Can we subject this person to a CAT scan? Can we subject this person to an X-ray? What about this medicine? So we always consult with them, making sure that a particular medicine and certain blood thinners we cannot use during pregnancy. So we have to be very particular with that regard when we're dealing with a pregnant patient.
Okay, right. Then how long does it take for someone to recover from after the ICU admission?
People think of ICU, and for us also, we take care of a patient in a very bad situation. We stabilize and send the patient out of the ICU. We never then, see the patient again, for that matter. But you ask a very important question. A stay in the hospital, more so in the ICU, is not just the stay in and going out. A lot of times it takes a lot of effort with regards to rehab. A patient who comes in with stroke may not be able to go back straight home. So from the ICU, they will go to step down, then to the floor, and then they may have to go to a rehab facility to gain strength. Sometimes when you have people with respiratory failure and they have a breathing tube that goes through the mouth, and if it's 21 days, we cannot get the breathing tube out, we do what is called as a tracheostomy. And obviously they cannot be cared for at home. So they have to go to a specific place called a long-term acute care facility or hospital. But more importantly, only today I read in the news that only 29% of patients who were admitted to the hospital for COVID-19 in United Kingdom a year later were independent. Means they still had effects of hospital admission. And obviously, if you were in the ICU, things were worse. So what was still lingering a year later, mind you, a year later after COVID-19 admission was still weakness, mental fog, lack of sleep, psychiatric issues. So these are some things, people face. Being in the ICU is not an easy thing. And so it takes a lot of, effort by multiple disciplines to get the people back to the condition they were in before they got sick.
Definitely. So then what should someone as a loved one do to help the one who was under the intensive care?
It's not a good situation. Obviously, the near and dear ones, they are affected a lot. So here, at least when someone is admitted to the ICU and they're in a pretty bad shape in the sense that, they have a breathing machine, they have, multiple medications that we are giving, they are heavily sedated, they cannot participate. It is incumbent on us as physicians, to carry out a conversation with the near and dear ones, constantly updating them and providing them the best assessment one has. We as intensivists see these a lot. So sometimes we can figure out where the trajectory of the patient is, but a lot of times, we have to give time. And the one thing I have realized that someone may come in really sick, and within the first few minutes, you should not look at the patient and just give up. A lot of times you work with these patients for 24 hours, 48 hours, what looks like really critical illness. These patients, a lot of these walk out of the ICU. So I don't want to give false hope to the near and dear ones, but certainly let them know that what we are doing, what are the injuries involved, or what is the status be upfront with the family members and constantly provide them update and reassurance, but also be realistic as to where things are heading. And obviously, when things are not headed in the right direction, at least I am upfront. And one of the questions that often comes up, you ask someone who does not have, in general, much knowledge about medicine, what do you want done? The answer will be, I want everything done. That's not the right way to approach. I usually tell the family members, this is what is going on. This is going on with the heart. This is what is going on with the lungs. This is going on with the kidneys. This is what is going on with the brain. This is going on with your GI tract. So just give them the whole picture and say, this is what in my professional judgment I would recommend. So by that, I mean, goals of care, whether someone is a full code, whether someone is like a limited code, and in some situations we say a no code situation. So that kind of discussion, one has to have with the family members when the patient himself or herself cannot participate in the decision making. Sometimes patients have advanced directives that they say, they would not want to be put on the ventilator for X if the situation is terminal. Then, the patient himself or herself has made that decision. But a lot of times when there is no advanced directive, then you have to talk to the next of kin and update them constantly.
Absolutely. So I'm going to go for our last question. Can you tell us about the after ICU care, regarding the patient's diet or the physical activity routine?
So again, as I said, a lot of times, when patients come in, depending upon what the underlying cause is, as I mentioned, one of the things we also do at our institution is something called ECMO. That's an extreme form of support to a patient, and it stands for extracorporeal membrane oxygenation. And basically, if someone has the lungs not working, we put someone on VV ECMO. If someone is lungs and heart, both are not working, then we put someone on what is called as VA ECMO. So during this COVID pandemic, we've had patients on VV ECMO for over 100 days, basically supported on artificial machines supporting their lungs because their lungs are in such bad position. So you have to individualize each patient. Now, this person, even if he or she makes it after 100 days, we are looking at, a very long haul, regarding rehabilitation, and, it will take months, if not years, for that person to come back to the usual state. So one thing I tell, as an intensivist or a critical care physician, we have a lot of tools, as I mentioned, whether it is a breathing tube, whether it's a dialysis catheter, whether it is putting other things in an individual, we can keep adding, to the patient. And when we work in the ICU, we work in consultation with other physicians. So when you have a heart doctor coming in, he's looking at the patient from the heart standpoint. When you have a kidney doctor coming in, he's looking at the patient from a kidney standpoint. When you have a liver doctor coming in, he's looking, so they can keep adding things, but we as intensivists have to look at the big picture. So I tell, all my students, at least at work, we must do as much as possible for the patient and as little as possible to the patient. So we can do a lot of things to the patient, but we should do as much as possible for the patient. So to make sure that the outcome is what everyone would desire.
That was wonderful. Thank you so much, Doctor, for walking us through this very critical topic and informing us everything about the intensive critical care. I'm sure it will be of great help to everyone listening to us right now. Thank you so much.
Thank you so much.